Hi, Erin. Uh-uh.
Hello, can you hear me?
Yes, I can hear you.
How are you guys doing?
Good. How about you?
Good.
Good, good.
So, we'll start with our case and then move to our didactic. Um, and I guess we just want to make sure that you all are good with the screen sharing and all that fun stuff. I'm sure we all are, but still run
Yeah,
into
yeah.
roadblocks every now and then.
I would love to like practice that and make sure it looks okay. And this is a something I should definitely know, but I'm having trouble even finding like presenter view on uh, like on PowerPoint.
Okay.
Mm,
Let's see. Pull it up, then maybe we can
Okay.
talk you through it. Okay. The easiest way is the little um, podium at the bottom. Let's see, beside the minus sign to the right a little bit. There, oops.
Oh, right.
Yeah, clicking on that.
Okay.
That's the easiest way.
Okay. Thank you.
You're welcome. So you are good to go. And let's see, Dr. Hermenau, is that how you pronounce your name?
Yeah, yep. S- So, I was under the impression that this was I had to prepare a case and a didactic portion.
Okay.
Is that not the case?
Well, as long as it's all within 20 minutes.
Oh, wow, okay. Yeah, I just wasn't really informed of a lot of this. So, I can just do like half the presentation, honestly, because it's gonna be too long, so.
Okay, so just the presentation, the didactic.
I'll go through it quicker now that I know that. It can be sped up, but I just didn't know that.
Okay. Sorry about that. All right, well, I'm going to, let's see, we might have to stop sharing your screen.
Okay, sure.
We might have some introductory slides. We'll see what Dr. Cantor wants to do. And Dr. Hermanel, you're good with your slides and all?
Yeah, I mean, do you want me to just try and like share just to see if it make sure it works real quick or? Okay, sure. Let me see. Can you see my screen?
Yes.
Okay, awesome.
Thank you.
No problem.
I am not a cow. Don't worry. Just give everybody a couple more minutes to join.
Sorry.
Welcome, everyone. If you're just joining, we're going to give everybody a few more minutes. All right, everybody, welcome. Let us go ahead and get started. Sonia, can you put up our COE and COI and all those good things?
Okay, great. So we have our CME information, our accreditation and EOE statements. There are no disclosures that Dr. Hermenau has to share with us. And you can click on, scan the QR code on the screen or click on the link here in the chat box for your CME.
Awesome, thank you. And as we always do, we are going to start off with our case today. And I think Erin from Kentucky has our case today, our adult nurse practitioner, doctor of nurse practitioning, however you say that appropriately. Welcome and thank you for your case today. And here we go.
Right. So I'm going to present an adult sickle cell case, and let me just advance the slide here. Sorry. Sorry, I'm sharing, but then now there we go. Okay. So this is a case of a patient that is currently in the hospital. I actually don't work on the inpatient side. I'm more managing on the clinic side, but I wanted to kind of give you an idea of she's a high utilizer with frequent hospitalization. So just wanted to give you an idea of her hospital course currently, and then also kind of long-term planning for her. So this patient did recently present to the hospital on September the 29th with complaints of sickle cell pain. And she actually continues to be hospitalized for pain crisis. She is a 27-year-old African-American female with sickle cell hemoglobin SC disease. She is employed. She works for her grandparents' cleaning business, and she does say that this being somewhat physical labor causes more sickle cell pain. She's what I would consider to be a high utilizer. She has been admitted to the hospital 10 times since October of 2022. She has had 17 ED visits. She calls weekly when she's not hospitalized, asking to come in for pain management. We do have an outpatient infusion center, and patients are able to come in and get a couple of doses of Dilaudid, a dose of Toradol, to kind of help prevent them from having to go to the ED or be hospitalized for pain crisis. So I was trying to count back, and I'm trying to encourage her not coming in so frequently, but it looks like she's been in potentially around over 30 times this year to our outpatient area for IV pain management. She did at one point, she thought she wanted to transition to another facility or another organization, and was hospitalized with them a couple of times. At that other facility, in their note, they had noted that they wanted to put her on a PCA pump, and she pretty much refused and demanded IV Dilaudid every 2 hours, and then refused Lyrica and was displaying opioid seeking behavior. As far as her pediatric course, she did have a history of asthma, acute chest, and fibromyalgia as a pediatric patient. She was on monthly exchange at some point. She doesn't really remember why she came off. And then there is concern for possible adverse childhood experiences by our LCSW who has worked with her and is developing a relationship with her, just based on her physiologic symptoms, expressions of guilt, shame, and anger. As far as her labs, as of yesterday, her hemoglobin was 10.7, hematocrit 29.4, her white count was 11.45, ANC was 5,000, MCV was 75, her retic count was 4.9, her creatinine was 0.66, GFR 126, her total bili was 1.3. She does complain of chest pain frequently. Her troponin was negative, EKGs were negative, and then she consistently, they'll draw a D-dimer when she comes into the ED, and it was elevated at 1,415. She did have a peripheral smear that did show sickle cells, but according to the attending physician that I collaborate with, and I know that's questionable whether or not that's accurate. Our attending does do that sometimes, but he said that was the first time he had seen sickle cells on a smear for her. And then you can see her last electrophoresis, which was 2000. It's been a while since she's had one. We do periodically tox screen. She didn't have any concern for like illicit drug use. She was positive for taking her home oxycodone. And then her current vitals, she has had a few elevated blood pressures related to pain or anxiety since she's been admitted. She has been on room air, SATs between 92 and 98%. Her BMI is 38. So she has had multiple CT angiograms with IV contrast performed during her multiple ED visits. She has had an extensive cardiac workup, which has been negative. She did have some atelectasis on a recent X-ray. She had a CT of the chest done in May, which was negative. She's had an X-ray of her spine done in May, which was negative. I did order an MRI of her lumbar spine recently, just because she's had this ongoing complaint of, she comes in for crisis of low back pain. She complains sometimes of bilateral leg pain. She hasn't had any evidence of a clot, and then no evidence of like AVN with past hip X-rays. In February, she was having some headaches. All of her CT and MRI were negative. So her current outpatient regimen, she does have a history of asthma, so she's on albuterol. She is on Buspar for anxiety, Sertrazine for allergies, Duloxetine. I had recommended 60. I think she takes 30 daily. I don't know how consistent she is, honestly, with taking that, but it is prescribed. And then folic acid, she's prescribed 2,000 milligrams of hydroxyurea daily, which she says she takes, but her MCD was 75 the last time I checked her CBC. She is on Singular, she's on Zofran, Phenagrin, and then she is given Percocet to manage, I guess, potential pain crisis at home. And she is someone that she's given 120 now, and she is getting that refilled like monthly. I encouraged her to try crizolizumab. She had about 6 doses of it over a year ago. She was a little unsure if it really worked. She did restart that. She received 1 dose. Then she was due for her like day 15 dose of that, and she's been in the hospital, and we're unable to give that, and she's hospitalized, so she missed that dose. So as far as her inpatient regimen, we've really been trying to advocate for some changes on our inpatient side and really encouraging more PCA use, but there's been some pushback, and we've just kind of been told like we don't have enough PCAs. So she's getting 2 milligrams of Dilaudid every 2 hours while in the hospital, and then weaned now to 2 milligrams every 3 hours. And then alternating with Percocet, 5s or 10s for severe pain, and then getting normal saline now to 100, and then continuing her home medication. The hematologist I work with did recommend her trying exchange yesterday. She said she was very hesitant. Apparently, I have been like advocating for her to try exchange for a while, and kind of said that our attending said was kind of saying like that she didn't know if I would recommend that, which was kind of odd because I've been pushing for that. So there's some kind of inconsistency with her story there. And then, so we do have an LCSW working with her. We go back. Okay. And so just to give you an idea of his approach with her, he's definitely trying to work with her weekly, trying to build strong relationship with her. And you can read his approach here. He is also encouraging her to engage in art therapy weekly. So that has started. The art therapist is seeing her in the hospital, practicing a lot of like deep breathing. She has a lot of physiologic symptoms of anxiety, and then some trauma-focused cognitive behavioral therapy as well. So our plan for her would be to continue crizolizumab, discussion of her compliance with the hydroxyurea. We definitely discussed the possibility of starting monthly exchange transfusions for her, and we do collaborate with our pediatric team to do that, as we don't have the option to do that on our adult side. So we collaborate with the peds team. I did order an MRI recently to work up this back pain more. And I think in my earlier slide, I hope I mentioned her current pain or complaint of pain, and pretty much typical complaint of pain is like right chest, bilateral leg, and low back. She is on Cymbalta. She needs to really take 60 daily if she can tolerate it. And then one thought is to consider Neurontin or Lyrica for pain management. Lyrica was recommended at the other facility, and she didn't really want to try it, but it's an option. And then one option would be considering transition to methadone for pain management. We don't have an attending here, and I'm not really honestly sure about Kentucky state law if we could even do Suboxone. I know more people are utilizing Suboxone, but we don't really have a prescriber willing to prescribe that. But our attending does sometimes prescribe methadone. And then, of course, encouraging her to adhere to sickle cell maintenance recommendations. the normal recommendations as far as vaccines, echoes to rule out pulmonary hypertension, microalbumins, and then with her having SC, a yearly dilated eye exam. Definitely encouraging her to continue working with our LCSW and with art therapy. Physical therapy could be beneficial. I've recommended her go in the past. She hasn't been very compliant with that, but she does have that back pain, those complaints, and her BMI is 38. Of course, encouraging weight loss, healthy diet, exercise. And then I've tried to wean her off all of these infusion visits, kind of given her a goal of like, this next month, you can only come in 3 times a month. And then after that, 2 times a month, because you really shouldn't be in crisis every week. And tried to explain, our concerns about opioid dependency. She's very hesitant, and it is honestly very hard for me to know what to do when she's calling saying she's in severe pain. She thinks she's in crisis. So any help with how to manage that would be beneficial. From a system level, we're really trying to encourage more PCA use in the hospital rather than giving IV push narcotics. We're encouraging transitioning to PO Benadryl. We no longer use IV Benadryl in our infusion center, but the hospital still uses IV Benadryl, which is hard to get the system to change that. But and then I talked about this case with Dr. Raj, actually, our pediatric provider, and he recommended maybe developing some individualized ER care plans for our patients. The patient has had, looks like 9 CT angiograms in this past year. Thankfully, she has normal kidney function, but they're drawing a D-dimer and that's elevated, and then they're automatically doing a CT angiogram. So she's being exposed to a lot of contrast. So these individualized plans would help prevent things like that from happening. And then we are monitoring narcotic use much more aggressively, and we do now have narcotic agreements, trying to do more consistent talk screens, and then really monitoring for these like frequent refill requests, and trying to have better discussions with how much opioid is being used. So as far as discussion, I just wanted to know more about how you would manage this patient in your center. How would you manage the weekly request to come in for outpatient pain management for sickle cell crisis? And then to what dosage of Dilaudid are you typically giving? Because I feel like there's a wide range of what I'm seeing given in different centers. And then do you feel the patient would benefit from monthly exchange? And how do you approach it if the patient is resistant to that? And then also just any experience you've had with individualized ER care plans and your thoughts on IV versus PO Benadryl and PCA use in the inpatient center.
So I'm going to start off by saying, sounds like you've made some great headway, and yes, you got a lot to do, but you're getting there. Just in general, I think with some of the systems issues that you've talked to us about. To help you out, the National Alliance of Sickle Cell Centers has developed some inpatient consensus recommendations that will be published as fast as we can move to publish them, that will include that we recommend only PCA in the hospital with no basal rate, and never ever giving IV Benadryl related to opioid pruritus. That really, you save IV Benadryl for anaphylaxis and that's it.
Okay.
And so we're doing that because we have a lot of systems like yours that just won't listen. And hopefully by putting that out on paper, that will help you do that. So that's coming. We're putting together a draft that's not yet been published that we can, I hope, give you in the next couple of weeks, just so you have it. You can tell people it's coming, just because, it'll take 6 months to get something on paper. But I think that would help you. I think that these cases are always hard. I'm sure that you'll get 8 different opinions on how to manage this person. I think there are a lot of things. I think obesity has a lot of pain-related symptomatology, and all we do is make it worse with opiates. And I think we see that a lot in our SC patients. It's something that I would love to look at and understand better. So one thing I would make sure is that you have a good primary care doctor who is managing her obesity and potentially even adding medication. There obviously are some great medications now out there, but making sure you have a really good PCP is going to be key also to her severe anxiety. And then I would absolutely put her on exchange transfusions. Right now this is what I always tell people. They have, I try to explain that I think they have terrible pain. I absolutely believe your pain. It's just that not all your pain is from sickle cell disease. And we spent a long time trying to say, is this crisis? Is it not crisis? And we have some people very similar to this lady who just, it doesn't matter. Pain is pain is pain. And there's a lot of panic and PTSD around pain. So we just talk about that we're going to treat pain. We just may not always treat it with IV pain medicine, because right now you're right. You're not helping her. You don't have a crisis every week. And so, we don't want to be part of their detriment, but you definitely want to control her sickle cell. And the best way to do that is transfusions. So that would be my suggestion and even if it's manual exchanges, she doesn't want to port, that's fine. That's another option, but that's something that I would certainly do in this scenario. And then I would absolutely use an individualized care plan, and I would eventually either put her on methadone or Suboxone, depending on a couple of different other things, but I want to stop talking so others can talk. I'm sure others have things to say.
Yes, I am here. Hi, this is Elna from Emory Children's. I agree with what Julie has said, Dr. Kanta, but just a couple more additions. In addition to getting a PCP who can help manage that, I would also suggest a sleep study. She may have sleep apnea, which may be making her general overall function a little worse. And I don't know how sunny you guys are, but also maybe check your vitamin D. You may not hurt, and if she's coming frequently. I think one of the centers we had present said they give it when patients coming for their infusion. That might also help. And I totally agree. And the literature from the transplant folks show that a lot of patients, even after transplant, still can have some kind of form of chronic pain. Now, whether it is opioid-induced hyperalgesia or that priming, I don't think it's been fully elucidated, but most of us would say it may be some form of physiologic opioid dependence. And to not only validate her pain and reduce some of that inflammation, I agree with a short period of exchange transfusion. I would, go with a manual exchange. If you're not going to do it for over a year, there's maybe no point putting a line in. If you can do the phlebotomy and give her some back, almost an equal volume, that also validates that that you're trying to manage the sickle cell pain. And I don't think you're going to be successful in the long run with her if you do not, do either methadone or Suboxone. And now that you don't need an X waiver, people are just scared of Suboxone. It's actually pretty easy to do. So those are my thoughts.
Such a great point about the sleep study and sleep in general. I spent a lot of time talking about, do you sleep? Half of our patients have opioid sort of related, either pain related or opioid related sleep dysrhythmias in addition to obstructive sleep apnea. And if you don't, and I tell people all the time, if you don't sleep, you're going to hurt, right? Doesn't matter who you are. We all know how you feel when you get up and you've had a bad night's sleep. So I totally agree. All really good points. And the other thing that I do in this situation is really have a talk with this young lady and say, look, you're on the path to really dying of not really of your sickle cell disease, but of being in the hospital and all the complications that come with being in the hospital. And we need to talk about how we're going to get you on the right track and what are your goals, and, really have a whole plan of where do you want to be in 10 years? Because it's probably not dead. And some people really, you can get them to buy in. I've had others walk out of the room and say, you wished it on me and now I'm leaving.
Mm-hmm. That's true. And also the point about doing all those CT angiograms, her creatinine maybe 0.66 now. I have no idea what her baseline was maybe 2 years ago. Most of them have isostenuria and their creatinines usually stay low, particularly the women will be in the 0.4. So I don't know if she's already maybe, have gone up from 0.4 to 0.6, and it still looks normal on paper, but it may not be normal for her. So one bad acute chest and Dilaudid and Toradol and Zosine can just tip her over into multi-organ failure. So she needs to stay out of the hospital. And I think, you you may not only the pain plan, I think you should have a big FYI for the ED. They are interested in troponin and nobody dying of a heart attack. Sometimes a lot of patients with SC will come in with this splenic, phrenic nerve irritation, and it behaves like left-sided chest pain and, a heart attack. And they keep getting this, CT angiograms and stuff like that. And that will be the quickest way to get her to exit. One more of those. So put a big FYI, no more CT angiograms unless there is a high suspicion, and D-dimers are not predictive at all.
Yeah, we actually started getting baseline D-dimers on patients, mostly to prove that that was a useful test. We got them during COVID because we were trying to see if we could identify who might have clots secondary to COVID. But that actually helped us a lot. It helped them see that what the normal was for people who didn't believe it. And we've actually written 2 papers now about the Wells criteria being useful in sickle cell disease. And that's something else you can do. So if they're not hypoxic and not tachycardic, they probably don't have a clot. But I think it sounds like
this is
oh, sorry, go on, Melissa.
Well, I was just going to say, I usually can't do these Tuesdays, but I specifically made sure I could today because of the Suboxone talk and because of a patient like this, because Erin, I'm a pediatric provider and I don't have patients on this kind of opioids because we have a good pain program where we don't allow this to happen. But now I'm inheriting these patients as I'm doing some adult work in the Mississippi Delta. I saw a 39-year-old today who this exact same prescriptions, 120 Percocets every 30 days. And, I can try to taper someone off that by a long taper and using other medications. It's nearly impossible. So using either methadone or Suboxone, we have to learn how to use these. So in the state of Mississippi, I thought that you're supposed to take an 8-hour course to use Suboxone. I might be wrong. That might only be for addiction. But I want to learn how to use it right. And so telling you, I'm a pediatric provider who's done this for 25 years and have been hesitant to go to having the knowledge to be really, really comfortable using those on my own without my pain specialist. But because I'm seeing these patients now, I need to do that. So I think anyone, that's why I'm here. And that's why I'm going to learn that, because there's too many of these patients who we can help, because until she gets off those, that 120 Percocet a month, there's no hope for her. She has to get off those. She will hurt as long as she is on those. But it's a complex process. And I'm really glad that your social worker is now seeing her regularly, because without that component and that support, it's impossible. So nearly impossible. I would advise, I'm going to, and I would advise getting comfortable with one of the other, with the long acting opioids that don't have the opioid induced hyperalgesia component.
Yeah, there is that recommendation for the 8-hour training, but it actually isn't required.
No, I think what I was saying is that for the DEA, there's a one-time 8-hour recommendation, requirement that just came up this year. So if you're renewing this year and you've never done, it's a one-time that comes up at the time that you renew. So if you wanted to do the Suboxone, you could get that credit for that.
I will tell you, we're writing a paper as we speak, hopefully to be submitted the next week or so. We took the Johns Hopkins protocol that we're calling the David Carroll protocol, and we implemented it in the real world. And that's what our paper is, and telling you about the patients that we've now put on it. It's already outdated. We probably doubled our patient numbers by now, including, very interestingly, 5 post-transplant and gene therapy patients. 2 of whom were still having tons of pain, and pain is gone with Suboxone. And it has made me realize what disservice we've done our patients by letting them up their opiates so far. Because it's fascinating. I have 2 patients who my biggest problem with them now is that I cannot get them to come in and do their transfusions. Or in one case, their Adakveo, which they were doing great on because they feel so good. And they're like, I don't need that anymore. All I need is Suboxone. Joy, I see you here. One specific individual who you and I both took care of, a young lady, she's now pregnant. And she was like, I'm just going to tell everybody all they need to treat their sickle cell is Suboxone. And I was like, okay, no, We still need to treat your sickle cell disease. Anyway, but it's not just a drug, right? You have to do all the other things. And so I think starting with the approach of you have a lot of pain, but we're not treating it very well, we're not helping you, is a good start. And kind of rewriting that. And, you know, some people are going to go with it and some people aren't. And one of the other things we're hoping to do is we want to develop a big D&I program so that we do a grant to help people implement this. And one of the things that we're starting to think about is peer mentors, because nobody wants to talk to us. They just want to talk to other people with sickle cell. And I think that'd be really beneficial too, because you think I'm an addict, that's why you want this. So I do have a handout for anybody who wants it that we use with patients, but a lot of it is just lots and lots of discussion.
I think that would be helpful. I think another thing too, Julie, leaving, you know, the great places like UAB and Hopkins is the culture behind treating opioid for patients with sickle cell disease. You know, it's usually what I'm seeing is two sides of the coin. Usually, you know, it's not great, or, you know, I don't want to say enabling, but, you know, patients with sickle cell disease need this to treat their disease. They need to be on high doses. And, you know, really educating patients about that this is actually doing the service to you, and also educating well-intended systems and institutions that this is, like, back in the day, we thought that it was needed because there was a lot of racism, but now the pendulum has swung too far, and now we have to swing it back and trying to get, you know, more buy-in too from other providers. So I think when you're starting something new that is very new, even among the sickle cell disease world, that's just something to think about, and having that grant of implementation with new hospital systems, and, you know, someone being on Suboxone and not everybody being like really scared that they're on Suboxone and can't treat their pain and stuff is also going to be important.
Yeah, I totally agree.
Yeah, hi, this is Tom Harrington. Matt is the next speaker, and I specifically asked him because we've had these discussions quite a bit, and the patients who are coming in, I'm sorry I missed the beginning, I was trying to get to a computer, but it sounds like you're describing these people who come in for like regular IV infusions of narcotics, and I have a few of these people that have sort of worked their way into a regular schedule, and I try to keep them out of it, but it's become quite a challenge. And most of those are probably good candidates for Suboxone. We've, you know, hoping to try to get something set up for that. But I would say for at least half of the, you know, 7 or 8 of these patients, it doesn't seem to make any change in how often they come to the hospital either. They get admitted almost just as often. I think if anything, maybe it makes them stay a little longer because they're a little more, you know, tolerant of narcotics. And I really would like to find the alternative, and Matt has been a great help in managing a lot of his patients, and hopefully we'll get the Suboxone going at our center. We don't have it fully going yet for our sickle cell patients.
Well, that was like the perfect introduction. So let's.
I know. I thought I'd do a little segue for you there.
Yep, perfect. Let's turn it over to Dr. Hermenau. I hope I said that right.
Hermenau, but close enough.
Hermenau?
Yeah, Hermenau. Thank you.
Oh, I added a D to your name. I apologize. He's our doctor of pharmacy here to talk to us about Suboxone today. He works as an inpatient pain stewardship clinical pharmacist at Jackson Memorial in Miami with a focus on acute pain, palliative care, and addiction. So I will turn it over to you.
Thank you very much for the introduction. I accidentally included a patient case in here, so I'll go through my slides a little quickly because I know I don't have so much time. But today we're going to be talking about buprenorphine microinduction for sickle cell pain. And I'm going to give you like the worst case, like the most difficult way to like induct buprenorphine, like if someone's already on existing agents potentially, like in our patient case, actually someone on methadone, so, and a short acting agent in addition to that. So, but in general too, before I get into this, buprenorphine there are pain indications for like Butrans patch, Belbuca, which are buprenorphine products FDA approved for pain. Today, though, we're going to be talking about the generic for Suboxone, or Subutex, which is just plain buprenorphine in the sublingual form. So I don't have anything to disclose, and I do have opinions of my own and not of Jackson Health System where I work. So today we're going to be talking about the case going from a full agonist to that of a buprenorphine for sickle cell chronic pain. We're going to be talking about the general hematologic guidelines for non-opioid and opioid management of acute and chronic pain, explaining the rationale for using buprenorphine in chronic pain as opposed to a full agonist, and then going over the Bernese method, which is a microinduction of buprenorphine using off-label in pain management. And I don't have much time, but generally, which of the following agents are not recommended for acute sickle cell disease pain by our 2020 American Society of Hematology? If people just wanted to enter it into the chat, I can go through it in a sec too. Yeah, awesome. So seeing a lot of the answer is C, steroids. So kudos to all you guys who got that correct. We do not recommend steroids acutely for pain management while a patient is admitted with sickle cell crisis. So I'll briefly go through this patient case because I want to get to the didactic portion of buprenorphine. So this is a case from my last institution, actually at UF, but it was a 30-year-old male who had sickle cell disease, hemoglobin SS, DVT-PE with currently on apixaban, and obese with a BMI of 31, suffering from chronic hip pain with frequent crisis resulting in hospitalizations, about 1 per month. And he presents to the hospital with acute crisis and general pains all over after failing outpatient therapy. So generally from days 1 to 3, the patient was initially seen by hematology and acute pain management, and we basically had resumed the outpatient pain medications in addition to a PCA of hydromorphone with a generous demand dose of 0.5 milligrams every 10 minutes with no basal rate. Medical history is listed there, surgical history and family history. He doesn't endorse any signs of like opioid use disorder, not any impact of like the opioids affecting his personal life or his family life and relationships, or his relationship with his children and wife at home as well. So these are his medications and past therapies he's tried. So he's tried MS-Contin at a couple different doses, methadone, oxycodone up to 30 milligrams short acting, as well as a variety of non-opioids from gabapentinoids to muscle relaxants, SNRIs like duloxetine, and NSAIDs too. And this was his current outpatient regimen, which was methadone and oxycodone for severe pain, as well as, again, this variety of multimodal agents as well. So this is his regimen like in the hospital at the time when we started the PCA. As I mentioned, we resumed his outpatient regimen with the long-acting opioid in addition to the PCA, and he was receiving a IV push in addition to this in transition to the PCA, as well as his multimodal regimen from outpatient. So some pertinent labs, imaging, pain, and mood assessment. He weighs about 100 kilos, 5'10", normal renal function and anemic, but he's compliant with he takes hydroxyurea, his MCV's 110, saturating fine with oxygen on just, without oxygen, sorry, on room air. And we didn't EKG check because he's on methadone, which was normal. And there's really no like signs of AVN, but he does have some like mild degenerative signs in his L-spine. And his pain was an 8 out of 10. And when we were interviewing, with his goal of having like a 5 out of 10 to 6 out of 10, really wants to spend more time with his family and be out of the hospital less, and describes his pain as achiness, sharp, throbbing, kind of a generalized body pain. There is a left-sided hip pain that's greater than the right, and alleviating factors are sitting down and like medications. So briefly, I'll talk about the acute pain recommendations for opioids for our American Society of Hematology. There's really not much evidence that's established for a lot of this, but a low certainty of evidence for suggesting a tailored opioid dosing based on consideration of the baseline opioid therapy and prior effective therapy, meaning like everyone's individualized. Don't just go to one dose for every single patient. patients can come in that are opioid naive potentially, and we want to like make sure it's very tailored. And there's even make a point to say frequent acute treatment using an individualized regimen may be ineffective and detrimental to long-term care goals. So you want a more chronic paradigm with other approaches that may be necessary. So now talking about the non-opioid recommendations for acute pain from the American Society of Hematology, it's pretty interesting. Lately, there have been some additions, I feel like. The non-steroidal NSAIDs or not non-steroidal anti-inflammatory drugs, again, very low certainty of evidence, but we're just being cautious with this as its renal toxicity components. Patients have risk of ulceration or those have bleeding risk on full dose anticoagulation. So a short course of steroids has a very low certainty of evidence. Sub-anesthetic ketamine is actually becoming more popular, and I'm a pain pharmacist, so I see this like quite often for pain, and it's something that's being introduced more into sickle cell. We could do a whole nother talk on this, but I'll try to be brief, seeing as we don't have too much time. And then regional anesthesia, so like post-operative, if the patient gets a knee operation or a shoulder operation, are we doing like adductor canal blocks for knee operation to reduce opioid usage? For shoulder blocks, are they doing supra or infraclavicular nerve blocks too? So these are some things that you can talk about with your anesthesiologist at your hospital if a patient's undergoing a procedure. So now talk about the recommendations for chronic pain for non-opioids. And we make these additions of duloxetine, milnacipran, so some SNRIs, tricyclic antidepressants, and gabapentinoids, which all of these have a very low certainty of evidence. Like there's some evidence here, but at the same time, a lot of this data is driven from that of fibromyalgia. So it's interesting comparison, very different disease state, but that's where a lot of this evidence was pulled from for these recommendations. So let's talk about buprenorphine and buprenorphine for chronic pain. So buprenorphine is a partial agonist at the mu-opioid receptor and a full agonist at the ORL1 or opioid-like receptor 1. It's a weak kappa antagonist and actually has some theoretical benefit for depression, and it has a significantly greater analgesic potency than that of morphine and affinity for the opioid receptor. So while that of a we'll talk about that of a full agonist versus that of a partial agonist, the risk of respiratory depression is lower for that of Suboxone. And you're not going to see the ceiling effect for respiratory depression, as I mentioned, compared to that of a full agonist. And you might actually get a reduced incidence in allergic reactions. So itchiness, histamine, pruritus, that of like morphine or Dilaudid may be lower with that of buprenorphine. It has a very slow dissociation kinetics, so its half-life is actually relatively long, 1 to 2 days, and its analgesic duration is relatively long as well. I've seen patients that can take it 3 times a day, you can take it twice a day, and generally for opioid use disorder, however, patients will be taking it once daily, which is a different indication altogether. At a therapeutic dose, as I mentioned, the risk of respiratory depression appears to be lower than that of a full mu-opioid receptor agonist. But when you add in benzos, anticonvulsants, and like alcohol, that does drop down to the level of a normal full agonist or roughly near it. So we just want to take this into account, but as is, buprenorphine has a much lower risk of respiratory depression than that of a full agonist. So who's our ideal patient population for buprenorphine for chronic pain? I would say if any of your patients fit into some of these characteristics, maybe they could be a qualifying candidate for it. And this isn't just for sickle cell, this is for like chronic pain as a whole. So our patient is on a muscle relaxant, which could theoretically increase his respiratory depression risk with methadone and Percocet. He's taking more than 90 milligrams of morphine at home at baseline, and he does have an elevated BMI, which could, again, lead to like a later diagnosis of obstructive sleep apnea and just like interrupt his breathing. So what's the pain evidence for buprenorphine? Well, there's one study that shows from like traditionally like switching over from IR opioids to Suboxone was for a patient that was hospitalized. The patient was on quite a high dose of oxycodone, and they actually did a 16-day microinduction onto 40 milligrams daily, divided into 4 doses of buprenorphine. And there are actually stories of this patient afterwards in a discussion that the patient had virtually like very low pain afterwards and was more functionally had a lot of improvements in their functionality when they're even in corrections. There's also a great study that I want to like really go into, which is buprenorphine, and it just works so differently. And it actually is a qualitative study that describes transitioning to buprenorphine for chronic pain in a 2-year period. So we're going to be talking about that on the next slide. And then there's actually like for just general chronic pain, this doesn't include sickle cell patients, but it gives us an idea of like a retrospective chart review that shows what an actual patient was on for OMEs or oral morphine equivalents prior to actually switching over to buprenorphine. So we can get a general idea of like what we're looking at here with in terms of potency and the transition over from medications. So the average mean daily oral morphine equivalent prior to induction for these patients was 550 milligrams of morphine per day. And the average dose conversion for buprenorphine was about 28 milligrams, so pretty high dose. For pain, you may not need this. Sometimes patients have due to this alternative mechanism, they don't require a dose that's that of like that for addiction, where it's like 24 milligrams or higher. Sometimes it can be like 12 to 16 milligrams or even lower sometimes. So, but importantly, the VAS or visual analog pain scores were decreased from 7 to 3.5 in this case too. So this study that was qualitative actually had 13 patients that were mixed bag, 60 to 500 milligrams of morphine per day. 11 patients completed this study and 2 dropped out, but there were 5 major themes from this study. And it was really patients who were dissatisfied with full agonist opioids. They were uncertain with buprenorphine, whether it would actually help them or not. They had functional improvements with buprenorphine. They identified systematic barriers to pain treatment, which a lot of our sickle cell patients likely face and there was also the identification of a trusting relationship with the provider. So they're very open and honest that this may or may not help with your pain, but we're going to be here in the process and help you transition over. If you like it, okay, great. We're not going to force you over onto this at the same time. So these are actually the verbatim like descriptions of the patients, and it was really interesting to hear these experiences firsthand from these patients. And I've actually spoken to some patients that describe buprenorphine just acting differently. Like it almost dampens the pain versus that of a full agonist, which like you have a little rush of a sensation or almost like a high that lowers your pain. It's very different. It works in the background almost from what patients have told me. And from the first example, like there's a lot of hesitancy because patients know what a full agonist will do for them. They know that this is going to work in 15 minutes, but they're like a little ambivalent about what buprenorphine is going to do. So maybe discussing that a little more with the patient, feeling like, well, I can sense you're ambivalent, but let's talk about this a little more, really hear from them like what their thoughts are on this. And then this other patient said their pain faded into the background. One patient was just saying, I've been functioning really well, like no hospital stays, and I was in the hospital every other month. So functionality is like the gold standard for pain management, in my opinion. And some patients are saying, my mind is clear. I'm able to be more focused. I'm more aware. So if your patients are reporting being too sluggish or groggy with like that of a full agonist, buprenorphine is a potential option for them. Understand though that they always will, potentially not always, but facing different aspects or hurdles. As a pharmacist myself, I can tell you I'm on the phone with outpatient pharmacies about getting buprenorphine, and it's not stocked a lot of pharmacies, and there's definitely stigma and bias associated with it due to its indication for that of opioid use disorder. But if you're able to get over some of those hurdles and really break down barriers with your organization, it can be a very beneficial drug for patients. And there's one patient that said, if your patient's running out of medication or landing in the emergency room because of pain, yeah, they're definitely a candidate. So just some criteria potentially from firsthand patients who have sickle cell. So what is the Bernese method? There are different methods of converting over on buprenorphine. There was the original way, which is the traditional way where patients basically we had patients withdraw from opioids prior to getting onto buprenorphine, and it's very unpleasant. Potentially time consuming, and you're requiring a lot of monitoring, and then you give buprenorphine once their symptoms are really, really bad. The alternative method is like stop start, which is all the way to the right, where you basically stop the full agonist and you start buprenorphine at the next dosing interval. So if it's a short acting opioid, say Percocet, for example, in the last patient case we talked about, its half-life is generally 6 to 8 hours. So you could probably assume maybe even less than that, like 4 hours. So 5 half-lives, about 20 hours. So about 20 hours or so, 12 to 20 hours, it would probably be eliminated from their body. So you could stop the medication and start buprenorphine at the next dosing interval. And that may be easier if patients who are only on a short-acting opioid. And then the option that we're going to be discussing is microdosing. So this is a very slow up titration of buprenorphine while the patient's actually still on the full-acting opioid agonist. And it actually can be done at home. There's a lesser potential for withdrawal. And it may be a little bit easier for a patient who's also on a long-acting and a short-acting opioid at the same time. So we'll be talking about it with sublingual tablets of buprenorphine, but there are also the transdermal patch too, which is growing into favor as well. So this is the Bernese method in the literature that supports it. Essentially, they did 0.2 milligrams of IV repetitively over a 4 to 3 hour interval several times a day. And they found that while giving these small doses of buprenorphine, it didn't actually like cause precipitate withdrawal. So buprenorphine, it's a partial agonist, so it can actually displace the full agonist if you give a high enough dose right away. And because they gave much lower doses over a longer period of time, it actually kind of sits around the opioid receptor and slowly displaces that of the full agonist. So you don't have as much of a severe withdrawal. And I think there's importance with this too, because it kind of creates buy-in for the patients as well, because if they have a really bad reaction the first time they try it, they're not going to want to go back to it. And if you're able to kind of overcome this, that's a great, future approach. So generally for this patient case, the patient was initiated on their home regimen and consuming about 600 milligrams of morphine. And the patient we had some buy-in with the patient where we kind of explained that there's this option of this alternative medication because they want it to be less sedated and basically be more functional. So they don't want to be in the hospital as much as well, which is the goal of a lot of our patients. So we kind of introduced the idea of buprenorphine, and they read up on it a little bit and got some buy-in from the patient. So generally over the next 12 days or so, we slowly up titrated the buprenorphine dose. So up into the point where we staggered their decreasing of opioids, where the patient we'd stopped on day 8 the methadone entirely, and they were just using the IV pushes with PCA in the majority of the time. And we kept slowly increasing the dose of buprenorphine to about 8 milligrams 3 times a day, in which they were only on the PCA at that point, and their pain score started to subside. So the patient explained that they had a usual pain during their crisis with slight worsening and some mild diarrhea around day 8 when we were increasing the buprenorphine. And you'll kind of see this sometimes when the patient's on about 12 milligrams daily, 10 to 12 milligrams, they might have a little bit of a reaction potentially. But this was overcome shortly as we kept increasing the dose. And on day 12, they felt that they were ready to go home and their pain was adequately controlled at this time. So the key concepts for a transition for buprenorphine, it has to be a collaborative approach and you have to get buy-in from the patients. So a lot of patients want to read about it. And I think if you just look up buprenorphine, I just Googled it, you'll see like opioid use disorder or addiction. So I think patients are overwhelmed and they kind of worry that, am I an addict? Or do they think I'm an addict? And really explaining this to the patient that buprenorphine was first created, Buprenex, the IV version, was for pain. It wasn't for opioid use disorder. So like it's a medication that can be used for pain off label, and you no longer need an X waiver for it, and you will not be like persecuted for prescribing it for pain management. The practicality of it all, as I mentioned, the patient was on a long-acting opioid, so it actually is a lot easier if your patient's only on a short-acting opioid. If the practicality of insurance as well, and just understanding the barriers you may need for prior authorization. And then functionality too. Functionally, we want to look at how the patient's improving. Are they more coherent? Are they more concise? Are they able to like go about their daily lives, find like purpose and passion and what drives them? It's always like good things to ask your patient. So we'll finish here with a poll question, but what characteristics may warrant rotation to sublingual buprenorphine for chronic pain and sickle cell disease? Yep, so everyone's on the right path here. So the answer is D, all the above. So as I mentioned, if a patient's having potentially frequent hospitalizations, they're experiencing unpleasant adverse drug reactions from a current full agonist and running out of pain medications potentially early every month, it may be a consideration for that of starting or broaching the conversation of sublingual buprenorphine for chronic pain. So really, to just recap, there's mixed evidence on pain scores, functional change, and hospital admission rates for patients who switch from full agonists to sublingual buprenorphine. And patients who are dissatisfied with their current treatment of full agonists, not experiencing functional improvements and admitting to the hospital frequently may be candidates for therapy. Only providers with clinical experience, just understanding the pharmacokinetics, should initiate a induction from a full opioid agonist to an off-label pain indication. We just don't want to precipitate withdrawal here. And actually, I mean, this could be rephrased because I don't want to discourage anyone from starting buprenorphine for patients. I think that if you want to learn more, then absolutely. I don't think it hurts to reach out to, sometimes I have background in addiction medicine and pain. That's a good group to reach out to for potentially some of that. If you want to kind of get your feet wet, you could use some of the lower hanging fruits, which are Butrans and Belbuca as well, which are FDA approved for pain too. So we got plenty of options here. But that's all I had. If we wanted to maybe do a little discussion here, leave some time. Thank you.
That was fantastic. Thank you so much. And I'm especially, it's great to see anyone who works in addiction who uses a dose of buprenorphine that you notice. One of the problems we have when we talk to our addiction team members is they don't use as high a dose in people with chronic pain. And so I think that if you, just to sort of forewarn others, we have learned that our addiction team is not as familiar with using Suboxone in this way. And so really often underdose patients, which is part of why then they don't want to take it because they feel like their pain wasn't controlled. So just something else to think about, but I'm sure you all have questions for Dr. Hermenau and not for me.
I just want to say one thing. First of all, I am really happy I get a chance to work with Matt. He missed his meeting this morning. What do you mean, Matt? We meet on a weekly basis to go over the inpatients. But, and I also wanted to say his high school picture looks really, really nice in the corner. You may have missed it. Matt, you mentioned that for obese, that, you know, a large, you know, people with large BMIs, it's more indicated. Is that because of the decreasing risk of sleep apnea, or is there some other like fat distribution or something else that may make that better?
Yeah, great question, Dr. Harrington. So yeah, with obesity, you have a, you know, like a larger neck circumference, which then leads to the risk of obstructive sleep apnea. And opioids as well, like in general too, like can cause like weight gain. So I mean, like in general, buprenorphine may not like help you lose weight, but there is like a lower risk of respiratory depression with just pure buprenorphine as a partial agonist versus that of a full agonist.
Okay, yeah, because several of the patients we've discussed happen to have that phenotype also. So hopefully we'll be able to get that going on them.
Absolutely, yeah.
That was fantastic. Thank you, and I'll be learning more and probably reaching out to you. In the case you used, you had a patient inpatient to make that transition. Do you advise on making that transition to outpatients as well, or is this something that you feel much more comfortable, both safety and withdrawal, and does it go better doing it inpatient?
Yeah, I mean, like in a monitored setting, it's a lot easier. Especially if they're on like a long acting agent like first, because like there's different ways you can go about it. And I guess I would assess the patient's medical literacy if they were to do that outpatient. For addiction, we actually do like instruct patients to do like a microinduction like outpatient sometimes. But like at the same time, if you have the ability to do an induction inpatient, it's just a lot easier. Understand though that you may be facing, like if a patient comes in a crisis, a couple days worth of like just trying to control the pain before actually doing an induction, because they just may not be feeling really to start that, even though it won't actually impact their pain control the first couple days because it's such a low dose. But in their minds, it's like an antagonist, or like that's just something to consider.
Anybody else? Last questions?
I just have a quick one. So I'm in pediatrics, so I think luckily, you know, with our kids that are on buprenorphine, we have it listed in their charts, and so they're going to go to a pediatric emergency room in the area. But with like the adults, how do you guys keep them on buprenorphine like long term? Like, who's to stop them from going to an urgent care for a pain episode and then getting, you know, whatever they would normally get, and then, you know, going off of the buprenorphine?
Well, I'll tell you, you know, we have patients who go everywhere, as you know, and We do a couple different things. So depends on buy-in. I find that most patients on buprenorphine don't actually need to go to the ER. They're controlling their disease really well. They are really that good. So that's one thing. The second thing is that if they do and they get IV Dilaudid, no big deal. 4 hours, put them back on their bup. No problem. Do it all the time. And we do that in our clinic too, to reassure patients that if they're not getting enough pain control during a crisis, we will switch them to regular Dilaudid or morphine and then just taper them back. Usually we microdose them back on while they're still in the hospital, but not always. So it's not really a limitation.
Yeah, and to piggyback off that as well, like you can always reduce the dose depending on, like, buprenorphine has a threshold in which it actually has opioid receptor mu opioid receptor occupancy. So like at a dose of like 4 milligrams 3 times a day, like around that 12 milligram mark, there's still about 20%, at least 20 to 30% of some occupancy remaining. So you could actually treat with a full agonist on top of buprenorphine if you wanted to. And if their pain was still uncontrolled, then you could stop the buprenorphine and then treat with full agonist and then do the microinduction back over.
Okay.
Well, thanks everybody. We're right at the bottom of the hour / top of the next hour. I have a feeling we're going to see a lot more Suboxone in our future, buprenorphine. So I'm sure we'll be continuing this conversation, and really want to thank everybody for your attention and attendance, and we'll see you guys in 2 weeks.
Thanks, Matt.